All right, good evening, everybody. It was not the best effort. I know it's been a long day for everybody, so I'll try one more time. Good evening, everybody.
Good evening.
There you go. So my name is Alden Landry. I'm the Faculty Assistant Director for the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. And I want to say thank you for staying strong and participating in this panel. I know it's late in the afternoon, evening, and we've been through so much with our conversations, talking about a myriad of issues that are impacting our communities of color and underrepresented minorities in medicine. And I'm excited to have this conversation, and I think it's going to be a great way to end our evening, mostly because I don't know if you all picked up on this, but there was always an undertone about what we were talking about throughout the day about, well, what if our healthcare workforce was more diverse? Whether it was the opening panel around social determinants of health or about precision medicine or immunizations, the conversation came up multiple times. And I think we have assembled a great panel here to help us join in this discussion and continue this discussion around workforce diversity and what it would mean if we had a more diverse healthcare workforce. So I'm going to just quickly introduce our panelists. So we have Vernell DeWitty, we have Donney John, we have Norma Hunter, we have Derek Robinson, and Fatima Cody Stanford. Fatima is a new inductee to the 40 Under 40.
No, I'm the inaugural class.
You were inaugural?
Yeah.
Forgive me. And Donney is also 40 Under 40. Just a couple notes that I want to make sure we go over. I want to set the ground rules. This is a conversation, and I really want you all to be engaged. But I've asked our panelists to really help set the stage for where we're at when it comes to diversity and inclusion in their particular fields. And I want to make sure that we give them time to do so. But I want to bring you all in when we start talking about solutions. Many of us have stories where we were the first, where we were the only, and more than likely we were lonely. And I think that a lot of us will be preaching to the choir if we continue to share our stories about how it was like when you were, the first in that class, or you were the only person in the hospital, or you were the only person in the C-suite. And while I appreciate that, I think more importantly, the conversation needs to be, how do we change it so that your success is the next person's success? How do we change it so that the experiences that you had, no one else has to go through? And how do we grow to scale some of these ideas that you may have? And how do we make these changes sustainable so that future generations don't have to deal with these same issues? So that's where I want you all to come in. And I ask politely that you keep your comments brief and make sure to focus on questions for our audience. I just want to start quickly by saying that I am a product of pipeline programs. I started with a program through the National Association of Minority Medical Educators when Hampton University invited a number of high school students down to a conference in New Orleans. And it was a phenomenal experience. And that was where I really recognized that there were so many people of color who were practicing in the health professions. And this was the first time I had really had that opportunity for that level of inspiration. And it led me to go to a small institution called Prairie View A&M University in Texas for undergrad. And I participated in an HCOP program there. And that HCOP program led me to apply to a summer program called the Minority Medical Education Program. And that minority medical education program offered me an opportunity to be exposed to a medical school that I ultimately went to for my medical training. And while I was there in medical school, I participated in another pipeline program called the Visiting Clerkship Program. And that was a program that brought me to Boston for my residency. And after participating in that program, I decided it was time for me to give back and start doing work in my own pipeline programs. And hopefully we'll have a chance to talk about the role of pipeline programs in the lives of our panelists, but also in your lives. And if that is a sustainable model that we can bring to the table, then maybe we should talk about how we can grow from the successes of our programs and talk more about what other opportunities are out there, like pipeline programs, to help diversify the workforce. I also want to make sure that we mention that there are some important numbers that we need to know about, and I'm going to let Norma really drive the discussion around the black men in medicine issue that we're dealing with. But the fact that in 1978 we had 542 black males accepted to medical school, but in 2014 we only had 515. That means we're going in the wrong direction. That means we're not doing something for a group that is often overlooked, often victimized, often abused, and mistreated within our education system. And that's leading to poor performances in K through 12. It's leading to missed opportunities at the undergraduate level, and it's leading to lack of opportunities when it comes to acceptance to medical school. So I want to make sure we bring home that point, because I think that's something that's important as well. I think we all want to talk about interprofessional education and how we can share best practices within each other's spheres of influence to make sure that we have that conversation as well. And so hopefully that'll set the tone for our conversation. I know our panelists have so much more that they're going to bring to the table. But what I want to do is just go down the line and have our panelists just give us basically an overview of where we're at for your particular field. And so just if you could tell us what your field is and where we're at when it comes to workforce diversity.
Hi, I'm Vernell DeWitty, and I am with the American Association of Colleges of Nursing. Nurses comprise the largest segment of the healthcare workforce. We're some 2.9 million strong, and the demand for nursing is expected to increase by an additional 15% by the year 2026. Part of this has to do with the aging population and the increased changes that are taking place in the demographics of our country. In terms of the workforce diversity, nursing is predominantly a white female profession, contrary to what some might think. White Caucasians make up about 67% of the nursing workforce, and the rest among the diversity. We have some groups that are more highly represented than others. African American nurses are about some 10.5% of the nursing workforce. Hispanics are about 9%. We continue to want to increase the diversity in nursing, but there are some real challenges in doing that, and we'll talk about some of those as we move along.
Donney, same question to you.
So hi everybody, my name is Donney John. I'm a pharmacist, a St. John's graduate, so anybody from New York, St. John's? So I started my career in pharmacy because I had a mother who was a nurse. So I had a chance to witness firsthand the value of learning interprofessional collaboration. Seeing from her being a pediatric nurse, the value of working with children and also the complications with dealing with medications. So it kind of inspired me to kind of go down my path, but also respect the disciplines that are within healthcare. And within pharmacy, we have an overabundance of pharmacy schools, where about 20 years ago, there was a handful, about 80 schools, and now we're pushing close to 150. So what that created was we had this huge shortage of pharmacists because we have a baby boomer generation that we're gonna not have enough pharmacists. So what you have in pharmacy makeup is a lot of Caucasian individuals, a lot of Asians, but then very small snippets of African Americans and Hispanics within pharmacy schools. You have only 5 HBCUs and only 2 or 3 have pharmacy programs that are putting out a substantial amount of candidates. But the problem is the workforce, we're all congregated in specific locations, and the job market is very diverse. But it's not easy for us to pick up from where we got trained or where we live to go to a remote area. You know, if you're in Virginia and you want to go to the southern state of Virginia, it's not easy if you have a family or other commitments. You want to work and live in your neighborhood. And that used to be the case when I first got into pharmacy school, is that the opportunities were endless, where I chose a career in academia, which was very far and few between when I came out of school, where people were getting big sign-on bonuses and everyone's questioning my decision. But for me, I understood the value in teaching, and the fact if I did a training program, it sets me up for long-term success. But it's hard as a young student graduating college where you have offer of a 6-figure salary, or do you take a pay cut to go into academia, go through a training route, and then build yourself up to eventually get to a comfortable lifestyle. So it is a very hard choice that many pharmacists have to decide, where they have a lot of loans, just like any other healthcare profession, and then you need to figure out, where's my upward mobility? So you take a big paycheck and then you plateau. So what I always tell students, because I was in academia for a long time, is that you marry the opportunity, not the paycheck. Because when you marry that paycheck, you have to settle. You have to get in a routine and you're not evolving. And every job has an opportunity for us to advance, but it's what we take out of that to really learn and grow from it. And so there is a lot of push to get more diversity in the workforce, but within pharmacy, there needs to be even a bigger push to get more diverse faculty within the pharmacy schools across the country. Because when you have faculty that represent the general populace, there are more people that are interested in going to the pharmacy profession, but also the mistrust within medicine. We talked, a lot of our conversation today was about research and the high cost of prescription drugs and why people are not taking it. When you don't have people that understand the cultural context of it, it's very hard to engage. I was fortunate to be in New York and learn within such a diverse demographic of how different cultures interact and also what are the stigmas associated with it. But that's not the luxury that everybody has. And from an academic teaching standpoint, we do need to do a better job of recruiting individuals to go into academia that have that fresh perspective, that can kind of talk about implicit bias and cultural competency, health literacy, to really make a difference in the grand scheme of things. You know, oftentimes I'm the only pharmacist that walks into a room, but as soon as I say I'm a pharmacist, people kind of shut me down, saying, what do you know? How would you know about any of this? What do you know about nursing? What do you know about medicine? But if I go into a room and I say I'm a healthcare professional, the dynamics change. I let my voice and my knowledge stand out, and then people will ask me later, well, where did you get your training from? And I say, I went to St. John's, I'm a pharmacist. They're like, you're a pharmacist? How do you know about this stuff? I'm like, because I actually work with people. I'm focusing on changing behavior, because I really am empathetic to making sure people are improving and being sustainable in their health. So it's very, very easy for us to have a turf war of the physician-led, nurse-led strategies or so-and-so-led strategies, but it's not enough of collaboration where we're respecting that there are limitations. An average physician visit is about 15 minutes, and out of that visit, 7 minutes is really patient care. There's a lot that you have to bill for within that 7 minutes of care. But if you have nurses and pharmacists and MAs and other ancillary staff really engaged, you could be a lot more efficient in terms of providing patient care and continuity of care.
Thank you, Donney. Norma?
Hi, good evening, everyone. Norma Paul Hunter. So I work at the Association of American Medical Colleges. You know, we represent about 154 now MD granting institutions across the United States. I'm trained as a psychologist. When I first started at the AMC, we had 126 institutions. And so within a very short amount of time, we've grown. And unfortunately, we can't say the same in terms of the numbers of historically underrepresented groups, African American, Latino American, Indian, Alaska Native. When we look at the percentage, the percentage has been relatively the same over the last 10, 15 years, that hovers around 14, 15%, hasn't exceeded 15% in over 20 years. And so we have to ask ourselves, what are the solutions? So I'm excited to be here today because we need to talk and think differently about how we increase diversity in medicine. We find that pipeline programs, pre-med programs are critical, but we also know that we have to start early. What we're finding is that we're losing young people at very early stages. Psychological research tells us that students begin to foreclose, young kids as early as second grade begin to foreclose on careers, which means that they decide they don't want certain careers because they don't see those role models. They don't understand what the pathway is because they're not exposed to it. And so we find that we have to think of solutions, not only what we're already doing, but what are other things outside the box? How do we leverage technology? How do we reach deeper into communities? Recently, the AMC released an analysis in brief that showed that about 20%, well, I should start with 80% of individuals entering medical school, their family incomes are the top 5th quintiles of US income. And that's a trend that's now over 30 years. And so when we talk about increasing diversity, we have to think about the intersections of race, socioeconomic status, gender, and other factors. Alden mentioned, our report, Altering the Course, looking at Black men in medicine, recognizing that we really have a lot of work to do. And it's not just about engaging young people in their interest in medicine and science, but it's also about systems change. And so we not only have to work at the individual level, but we have to really work within the systems that are deeply rooted, unfortunately, in broader socio-political issues like racism. And so we find that we really have to work together. And so I'm excited about this conversation today to think about how AMC could work with various partners to really alter the course, not only for Black men, but also what we see as a national crisis for American Indians and Alaska Natives in medicine.
Perfect. Thank you for that. Derek?
Good evening, Alden, and good evening to the panelists. Thank you all for the opportunity to be here. My name is Derek Robinson. I'm Vice President and Chief Medical Officer at Blue Cross Blue Shield of Illinois, as well as Healthcare Service Corporation, which is our parent company. We insure about 8 million individuals in the state of Illinois and about 16 million individuals across the 5 states where we offer Blue Cross Blue Shield insurance. And diversity obviously is a big challenge on the corporate side. I'm in a unique situation where the president of my Blue Cross Blue Shield of Illinois plan is actually an African-American man. One of the few African-American leaders of a multi-billion-dollar health insurance company in the U.S. So I've got this unique experience right now, and I'm very much appreciative of it. When we look out more broadly across the corporate environment, there are significant challenges in terms of diversity and inclusion. An author, Susan Reed, the author of Diversity Index, did a study that looked at corporations across the U.S., and over a 20-year period from 1995 to 2005, the number of completely all-white executive teams actually declined from 67% to 33%. But she found it in 2015, we still have in the top 100 companies in the U.S., 50% of the executive teams are either all male or all white. And so when you look at the individuals who are serving in those senior executive roles, they set the tone for the organizations. They ask the important questions. And when you begin to look at hospitals and health systems, for example, the American Hospital Association did a study back in 2012 that evaluated the parity of representation of diverse populations that are patients versus those that are in administration. And for example, Hispanic Americans represent 9% of patients, but only 3% of the board members, or 3% of the executive suite. African Americans, 12% of patients, but only 6% of the board seats, and 7% of the executive team, C-suites roles. And you guys probably guess, so of those minorities that are in C-suite roles, what job did they have?
Chief Diversity Officer.
Chief Diversity Officer, 60%. 60% are the Chief Diversity Officers. And so it's a similar story. It's challenging to be the only one in that executive role. But I can tell you that when we have more diversity in executive teams, the questions that are answered are better. Mm-hmm. And you ask those important questions like health disparities. What are we doing as an organization to measure them, incentivize driving change, and it makes a difference. And so happy to be a part of the discussion today.
Wonderful. Last but not least.
Hi, I'm Dr. Fatima Cody, Stanford. I'm an obesity medicine physician scientist at Mass General Hospital and Harvard Medical School. What is obesity medicine, you might ask? I care for patients that have overweight and obesity within the pediatric and adult population. But as a physician scientist, I spent a great deal of my time conducting clinical research with regards to clinical research amongst the entire domain of looking at obesity from policy issues, et cetera. Just to give you a little bit of my background and really how I think about this, or the lens through which I view this, I was born and raised in Atlanta, Georgia. For any of you in the room that are from Atlanta, we are the best. And so my introduction to medicine, I think, was a bit skewed because in Atlanta, specifically within my zip code of 30331, we have more black doctors per capita than anywhere else in the United States. What that means is that my exposure to medicine as a potential for myself was one that seemed very, tangible. Every physician that I'd ever gone to in my entire life was an African-American physician, from my pediatrician to my gynecologist, my ophthalmologist, my cardiologist, and yes, I had all of those. They were all physicians, and so I just decided, one week I wanted to be this, and the next week I wanted to be this, because these were people that I saw in my community. These were people that were allowing me to shadow them. These are people that were introducing me very early into pipeline programs that I was engaged in from very early. In terms of looking at clinical research, which we haven't specifically talked about, what we do know is that there's a paucity of underrepresented minorities engaged in clinical research because we don't see it. But my first NIH grant came in the 10th grade when I started doing clinical research at Emory University through an NIH Minority in Medicine program. And so that exposure made it such that I wanted to pursue that as part of my career path. Now, as I made my way down this pipeline, which we have talked about being what we would call the leaky pipeline, what I found was that as I continued down that pathway, that the pipe continued to narrow. So what I found was that I had constraints on me that even though I was this high-performing student, people were often putting barriers or roadblocks along this pathway for me. I went to the Medical College of Georgia School of Medicine, and I often don't speak of that because it was such a treacherous experience. I started medical school, I ran for president of the class, which was a great thing, right? This is their first African-American class president since its founding in 1828, back in the early 2000s. And what I found was resistance all the way along that pathway. I had things thrown at me in class for almost 2 entire years. I mean, how do you navigate dealing with that as someone that's supposedly a high-performing individual who wants to contribute to your community when you can't even be accepted for who you are? So when we look at issues that I've dealt with recently, for you that may be familiar with the Delta Airlines experience, that just happened in October of last year, where I was told after showing my license or I guess the question I was asked was that, is that really your license? So here you are looking at my license from the Commonwealth of Massachusetts, which clearly indicates my name and my degree. Not all of, I have 4 degrees, you guys, but they only put 1 on there. They put the one that counted in this situation, and I was asked, is this really mine? So what we find is that I guess we were looking at systemic racism. How does this play out? So while I grew up in Atlanta, where everyone, all the doctors looked like me, and this was a tangible issue, and half of my cheerleading squad from the Atlanta public school system are actually physicians in practice, mostly in the Atlanta area, that was not what other people are seeing. So when I go into a plane, dressed in my cute red dress and my shoes, I am not perceived to be a doctor, even when having proof that indicates such. And so I think that this is part of that system. We are part of the converted in this room, right? We are the people that believe that persons that are diverse, that are in medicine, represent what we should have. But that's not what greater America believes to be the case. And we need to change that conversation in such a way that we get them to understand what we live every day.
All right. So I think we have a lot to unpack from our panelists, coming from sort of the imagery and our experiences, systemic racism, what it's like in the C-suite, health disparities, what kids are experiencing in K through 12, going in through to medical school, interprofessional education, who can play what role within careers in the health profession, careers in nursing experiences, how that compares to other health professions. And then obviously there's other professions that aren't represented on our panel, whether there's optometry or physical therapy and whatnot. And those fields also are suffering from these same, if not worse, diversity issues. So I guess maybe I'll start with Derek. So you mentioned health disparities. And I think we've been here before. We've talked about this a number of times throughout the day. The Institute of Medicine, now National Science, Academy of Medicine, talked about this in unequal treatment. But can you just give us a little bit of an intro into why diversity matters when it comes to health disparities?
Sure. So I think it matters from a couple of different perspectives. More broadly, we know that when we talk about elements of quality care, equity is one of the key components, but often it's one of those that's missed and ignored when we talk about quality. And so when you think about what happens as we measure quality from a health insurance perspective, right? We look at safety and timeliness and access and effectiveness and patient-centered, but equity is often something that's missing at the table. And partly that's because it just has not been a priority for organizations over time, but we recognize that disparities add, from our estimates, over $100 billion in excess direct medical costs on an annual basis, avoidable costs. And so these are things that we can do something about, but we have to prioritize them as being something that's important to do. We know that minority physicians are more likely to serve minority populations and low-income populations than majority physicians. And so that's something that's critically important. You know, we had an opportunity to work with the AAMC and several other organizations to host a physician diversity summit at Blue Cross Blue Shield of Illinois a couple of weeks ago. And when we looked at a map of where physicians of different racial and ethnic backgrounds actually practice across the Chicago area, and then we subtracted out all of those physicians and looked at just where the African American physicians practice, they were primarily on the south and west sides of Chicago. When we took them out and then reimposed all the other physicians, you saw this dearth of access to physicians in certain parts of the city that are predominantly black and brown. So what does that mean? You know, we began to add up all the things that we've talked about today in terms of fear of the healthcare system, mistrust, and then not having providers that you can access that individuals trust and feel are going to provide them with high quality care. And then certainly from the IOM report, we know that there are differences in the quality of care that's provided, and that we do have some systemic issues of racial inequality in the delivery of healthcare in the U.S. So diversity, I think, in the physician workforce and other parts of our healthcare workforce are critically important, and especially as our society becomes much more diverse, the underrepresentation is going to have an even more significant effect. And these aren't changes that we can affect overnight. It's going to take time to actually bridge the gap that we have.
Vernell, I want to bring you in.
I'd like to say something about the role of nursing in terms of the care delivery system. Nurses are always there. Nurses take care of patients at their most vulnerable moments. Nursing for 10 years in a row has been voted the most trusted profession by the Gallup poll. And I think the role of nursing and why we need nurses so very urgently is because everybody needs a nurse. And if you don't need one now, you're going to need one day soon. And I think that what we need to do is we need to think about the critical role that nurses play in terms of creating access to care for patients, for the continuity of care for patients. A physician might see a patient in the office. The nurse is going to be there after the patient discharged in the home providing care. So when you think about the increasing demand for nursing, it's because now care is delivered more than just in hospitals. They take place in community settings and in many other places. And the reason that diversity in nursing is so critical is that patients trust their nurse. They will say to their nurses things that they will not say to their physician. And a nurse who practices true cultural humility is able to really make a difference in terms of patient outcomes.
So you touched on cultural humility, and I want to jump to that in a second, but I want to make sure we're looking at this from sort of the beginning and going back to early in the pipeline and talking about what's happening with K through 12 education and STEM and exposure. And Fatima, your experience is different because you grew up in Atlanta. And so so I want you to hold on, participate in this.
Can't live in Wakanda.
But the rest of us, at least for me in particular, the first time I saw a black doctor was not until I was participating in these programs and getting exposure to careers in the health professions. And so, Norma, you mentioned earlier about the imprinting that kids have in second, third, fourth grade when it comes to choosing a career. So can you talk a little bit more about that on how important it is for students of color, especially at that early age, to have role models and mentors and early exposure at that time?
Sure. I mean, I think there are several theories in psychology, especially if you think about Bandura self-efficacy theory, you know, which children, what it's all about is exposure early on, being able to get messaging that tells you you can do this, you can be successful, the role modeling, but also the opportunity to try different things, right? And so many of our young people, if you think about if they're primarily concentrated in educational environments where there aren't as many resources, you know, maybe there aren't strong science teachers, maybe they don't have access to computers. I mean, I think we all know these stories already. That limits their potential, limits their opportunity to really think beyond what exists. And I think Fatima made a good point. You know, she saw everyone around her who looked like her and noticed that they were very capable. I mean, we talk a lot about that in terms of when we disaggregate the data and we think about our different communities of color within Latino communities. You know, some are actually succeeding quicker than Puerto Ricans, for example. My family is from Puerto Rico, and we find, unfortunately, over time, Puerto Ricans and Mexicans are lagging behind other Latinos, you know, in the United States in medicine from South and Central American countries. If you think about our African American communities, when we disaggregate, there's a lot of concern about individuals who are here from the United States, you know, years descendants of slaves versus those who are immigrant families and their success. So I think that part of it is thinking about where people are from, the communities they're exposed to, and then thinking about reaching deeply into those communities to make changes. And that's why I said earlier, we can't, sometimes it's interesting at the AMC, people are like, well, what is AMC doing to increase diversity? And we're like, we're trying to do a lot, but we can't do it alone because we really have to start early. And that's what we see. We have years and years of interventions, probably since the mid-70s. All of our medical schools right now, based according to that aligns with our mission, but also because LCME requires it, right? Have some kind of pipeline pre-med initiative, starting could be as early as elementary school all the way through post-baccalaureate levels. Every medical school has some kind of program. And so everyone's trying their best, but we're really trying to fight against other issues that start very early on. So part of it is how can we work together? How can we work with educational partners? How can we work with healthcare systems, healthcare providers? How do we really, if you think about the whole approach the Robert Wood Johnson Foundation is taking around the culture of health, how do we build a culture of health? How do we build a culture of education? How do we build a culture of careers in our communities so that everyone has an equal opportunity to succeed, and recognizing that not everyone starts in the same place?
Donney, did you want to jump in?
So you know what's one of the most effective ways within the past, I would say 10 years, of educating young kids about the future workforce, especially about medicine? Doc McStuffins. How many of you have kids? So if you have kids, you'll know about Doc McStuffins. But part of our first interaction with a healthcare professional, it comes within media. How we see certain roles, that we see police, fire, politicians, all these different roles on TV in some capacity. We have TV programs. There's a new medical drama, like almost every season, but there's very few that show a very diverse medical team. So when you look at shows like Doc McStuffins, where they're talking about asking basic questions, getting people to be compassionate, kissing the boo-boos, answering the questions, where kids feel more comfortable when they can bring their toys into the visit with them, because now the doctor can check the toy out before they check out the child. These are all little things that we don't take into account what we're watching and what we're seeing. There was a point in time back in the day where there was a certain level of esteem being in the medical profession, whether it was being a doctor, pharmacist, or nurse, or any other allied health professional. But when we look at what's everybody's goal right now, to be a YouTube star, an unboxer, if anybody has kids, they'll know what unboxing is, or a slime expert, but also an Instagram celebrity or an influencer or a public figure. But our priorities of what we're exposing our children to is different. So the whole esteem of being a physician, a pharmacist, or nurse, or any other healthcare professional is kind of taking a low end of the totem pole. The Gallup poll, as you pointed out, is exactly right. Nurses have been #1 for the past 17 years, physicians #2, and pharmacists #3. But that's it. We have a great Gallup poll that says that we're trusted, but the diversity in getting to that point is a challenge. And TV definitely plays a role where when people hear I'm a pharmacist, oh, like Breaking Bad. It's like, no, not like Breaking Bad. Like, I'm not going to make you mad. Yes, I do know how to make it, but I'm not going to make it. So we do have to be mindful of how we are portrayed in the media in terms of all of our roles, where Grey's Anatomy is one show that's been around for a long time, but does such a great job in diversity. When you look at the cast, it is one of the few shows for the longevity has had a very diverse workforce in terms of the neurosurgeon could be of all different ethnic backgrounds, the dermatologist, the nurses. There's a lot of diversity where we don't value that enough. And when we look back at it, we'll see that those type of shows of programming where they've educated the public about the diversity, that you can be a specific role without being defined by your race, is truly impactful.
Sure.
I think at the same time, though, we have messages, right, that are also very negative, especially to our men of color and black men, and what we see in the media as well, that we always have to counteract, and that remind us of what systems are in place that really work against these positive images as well.
And quickly, Fatima.
So I'll concur with that. I want to talk about when I practiced general pediatrics and internal medicine, what I would often do when I would see young children in the office, I would ask them what did they want to be when they grow up. That's a very simple question. And when we talk about black men in medicine, almost every young black boy that I would see in the office told me they wanted to do one of three things. They wanted to play in the NFL, they wanted to play in the NBA, or they wanted to play in Major League Baseball. And while those are fine professions and they do make significantly more than I will make in my lifetime, 0.001% of men will make it there. So if my entire pediatric practice, if all of them were to make it to the NBA, that would be statistically unlikely. So I would often ask them, so my follow-up question to them would be, well, what else would you want to be? And they would give me a blank stare. And they were like, well, that's just what I'm doing. And so I said, well, you know, are there other options? No, that's what I'm doing. And the mom would often, because it would often be the mom, well, that's what he's doing. I'm like, okay, well, that's fine, but are there other potential options? And so I think about this early foreclosure. I think maybe even if you were to look at that specifically for communities of color, that foreclosure may even happen prior to second grade, because the images that they see, and it's not that those aren't great professions, but there are so few people that actually make it. And even if you look at the longevity of it in the NFL, average duration is about 2 years that you're in the league. And so if you look at a lot of these people that actually make it, they are unfortunately without any resources pretty soon thereafter. So I think that we somehow have to expose them early, and maybe it's these things that we do in education. Maybe it's the questions that pediatricians or family physicians are asking these young children very early when they're seeing people like us in that setting. Hey, what do you want to be when you grow up? And if they only say sports figures, it's fine, but I would say challenge them to broaden their perspective.
I have a slightly different take on some of this, because in nursing, I think the issue is a little bit different. We have by far more persons who are qualified applicants for nursing school than we can accommodate. Last year, there were more than 60,000 qualified applicants who could not be admitted into nursing school. A lot of it has to do with lack of capacity, because lack of faculty. And another big selection criteria is that how schools make decisions in terms of who gets to go and who gets to learn. And a lot of it has to do with, of course, GPA, and you stack it up, and you know, even though you meet the GPA requirement, you're still not selected because it's not quite high enough, and that's where we start to talk about holistic admissions. So I think that there are probably some other factors that impact nursing profession that might be a little bit different.
And I think to that point, I think Fatima, you mentioned that about the squeezing or tightening of the pipeline as you've gone along. And I think we can all sort of share our experiences of how, despite knowing that we're capable and proving that we're capable, we're always thought of as less than or incapable. And sometimes it may be through test scores or GPAs or whatever it may be, or sometimes it may be through other coded hidden curriculum that we aren't aware of. And so maybe we could talk about some of the roadblocks that students may be facing when they enter into college and when they're in college and trying to move forward. One of the places that I often hear students hitting roadblocks is their advisors, the people that are supposed to be dream launchers, but instead they're gatekeepers and preventing students from advancing. So any comments about how we can make sure that from a collegiate standpoint, and maybe this is where we start to talk about pipeline programs, how we can work to get students other exposures to help them continue on this growth path once they've expressed interest and tried to make a commitment towards a career in the health professions.
Alden, I'll jump in. Unlike Fatima, when I grew up, I had not met an African-American physician until I went to college as well. I did have a chance to talk to one on the phone before making a decision on what college to go to. And I got launched into a great pipeline program at Xavier University of Louisiana, which has produced folks like Regina Benjamin and others. And so one of the things that Xavier does is they have a really great advising program for their pre-med students. They orient them to the application process to medical school very early. They're also really nurtured by having an environment where there are tons of many students that are interested. So it's success is sort of the norm, not an exception. And I don't think that exists in many of the institutions where we have underrepresented in medicine students that are applying for medical school or going down that track. And so I think we have to ensure that we're able to bolster up those pre-medical programs, that they've got good guidance, because we know that there are a lot of classes we have to take sequentially. And so if you don't get the fundamental classes taken when it's time to apply to medical school, you don't have the knowledge that you need to do well on the exam, for example. Or you're just really discouraged in the process. And so I think those are significant challenges that we have to be really aware of. And I think some of the work that other pipeline programs, some of the work that the AAMC and others are doing is helping bridge that gap. But we're not bridging it fast enough, and we've got to scale these programs a lot faster.
Vernell, did you want to jump in?
Yeah, I wanted to add to that. Another challenge that students of color encounter is often the unconscious bias and the stereotyping. Case in point, a week ago, I was interviewing a Native American student who was in her final year of nursing school, had been accepted into a graduate program at the University of Washington. And when I asked her to tell me what it was like going to school as a Native American student, because she lived on a reservation and had grown up there, the experience had been so painful that she started to cry, even though it was past. And she said that when she was in school, when she would go to clinical settings, the nurses that she would work with would look at her and say, "What are you doing here? You are not going to be a nurse. What makes you think that you can do this?" Now, I don't know if it's as blatant in many other places, but sometimes there is the implicit biases that come out, and sometimes they're very overt.
Very much so.
So I think that not having the support, not having faculty of color who are there to be the champion for the students and saying, you can do this, you can move forward, and then coaching them and opening the doors of opportunity. So I think those are some of the real problems that students experience that interfere with their success.
Great. And again, just because I know we're preaching to the choir, show of hands of somebody, if you've experienced unconscious bias from... Show of hands if you've experienced overt racism. All right, so we're all there. We're all there. We've all been there. We've all had it. We've all faced it, right? So I want to go back to a conversation that where we can launch into. One, talking about what's happening on our reservations with tribal colleges and then Hispanic serving institutions and also HBCUs, and how can we better partner, better invest, better work with these institutions to help diversify the healthcare workforce. And this was, again, a discussion that I heard many times throughout the day where we were talking about the roles of these institutions. So I just want to hear from our panelists, how can we leverage these opportunities?
Can I say something?
I'll get to you, Vernell.
Okay.
Don.
Okay.
He yielded the floor to you.
Okay, and I jump on this because I'm a product of an HBCU. I'm a graduate of Dillard University in New Orleans, and had an outstanding nursing program. However, what we find now is that for nursing schools that are at HBCUs, they're being really, really challenged in terms of the NCLEX pass rate. And NCLEX is the licensing exam for nursing. And if you don't pass your licensing exam, of course, you cannot practice. And over the years, lots of factors, including not having sufficient resources and other challenges that HBCUs experience, you find that the NCLEX pass rates are going down, and so that jeopardizes the school's accreditation. Right now, I'm involved with an initiative that includes the American Association of Colleges of Nursing, where I work, the National League for Nursing, the Center to Champion Nursing, which is at AARP, and the Office of Minority Health. And we have been hosting, and we'll host a second, a workshop with deans from HBCUs to begin to look at strategies to increase the NCLEX pass rate. And we need many more of those because those schools are in real jeopardy now.
So when you look at HBCUs, there's a lot of value in terms of what they can teach. But academia is a business. So at the end of the day, you know, when I was in academia, it was kind of a culture shock in looking at the sheer number of students that we have to put in. And if you did not pass a student, how many people you have to replace that student seat with, because there was a specific dollar amount tied to each student. The problem is that academia is not very collaborative, where we like to publish and we like to do stuff on our own. But when it comes to strength in numbers, there isn't that case there. And part of it has to be where, when you look at Native Americans and other groups where there's a need to get them into certain professions, HBCUs is such a great learning environment. And to leverage the relationship between the Native Americans and HBCUs seems like a common fit. And when you look at the general body of students within HBCUs, they're much different than what they were in the past. And we haven't really, some schools accept that and will accept the diversity, that it's not just an all African-American institution anymore, but it's a diverse Hispanic and Indian and Caucasian, diverse diversity of student population. But you have to accept the fact that times are changing, and because we're nomadic, people will go from different parts of the country to look for a better opportunity. So there's a part of it is the marketing of what you can learn and the value that's available at these institutions. But at the same time, you have to look at, I'll use St. John's where I went to school. It's in an urban environment, Jamaica, Queens. There is a lot of diversity. So to take a student from the Bronx or Brooklyn to tell them go to a HBCU or go to another university, when in your neighborhood you have great institutions that offer that richness and diversity, it becomes a problem. So we have to kind of figure out how do we build together, not it's either one or the other. And that's often a lot of the conversations like, well, we don't want to drain the talent from this region to another region. When you look at Temple University and the nursing program and things around Temple and Georgetown, these are great universities, just like many other universities, and their HBCUs are in the same vicinity. So there has to be more collaboration of kind of celebrating through research and progress together, not just it's them over there and them on here on the other side. So there's that collegiality that needs to improve.
So Derek, I want to get your thoughts, and then Norma, I want to get your thoughts about community colleges as well. Make sure we bring that into the discussion.
Sure. As I was listening to the comments, I was thinking about, the mission that many of our minority serving institutions have, and many of them serve students who may come from school systems that have not adequately prepared them, but that's what they specialize in doing. They embrace those students, build them up, ensure that they have the knowledge, the competencies that they need to be successful. But I was also thinking as a parent, I have a second grader who's doing these pretty complex word problems on computer software for math each day. And it just reminds me of some of the complexity of the type of problems that we have to take on many of the standardized exams. I know I wasn't taking those types of questions when I was going through probably elementary school or middle school. So when you think about some of the disparities that we may see in how education is promulgated across that pipeline and the challenges that some of the students may face as they get to college and university, it makes it a bit challenging to ensure that they're hitting the ball out of the park when we step into the standardized exams that in some instances haven't been designed in a way that allows them to best demonstrate their knowledge and their capacity to do well. And that is one of the challenges that we face. But I think the other thing is how do institutions view the optimal applicant for medical school or nursing school, and you alluded to that earlier. And we have to change that narrative as well, because it's not just about numbers. If it was just about numbers, individuals like myself would not be a physician today. If it was just about the quantitative number being the definition for what makes a good healthcare professional or a good healthcare leader, I wouldn't be here. And there are a number of stories that are like that as well. And so we have to deal with both sides of that equation, ensuring that the systems that we operate in aren't designed to exclude and weed out students who are going to go and serve their communities and do it in an excellent fashion, address many of the disparities and inequities that we've talked about, because that's part of the challenge that we see.
And Norma, about the community colleges?
Sure. I want to say something about tribal colleges and universities. Recently, the AMC worked with the Association of American Indian Physicians on a report called Reshaping the Journey, American Indians and Alaska Natives in Medicine. And what we found was we just dug a little bit deeper into the data to really understand what's happening with American Indians and Alaska Natives over 20 years. And really, it really is a crisis. The numbers have decreased over time. We do see some increases in terms of individuals who identify as American Indian and another race. But really what we found was going to where people are, right? We talked about the minority serving institutions. Even with the tribal colleges, over a 5-year period, we only had about 3 individuals who applied to MD school over the 5-year period, and none of those ended up in our medical schools. And so part of it is we know where our communities are. We know where the issues, if you think about hotspotting initiatives, we know where the hotspots are. We need to go into those communities and work with them. And what we find is when we work with our colleagues, American Indian, Alaska Native colleagues, what they told us is that they're tired of really hearing that they don't even exist, Some people don't even acknowledge that American Indian, Alaska Native communities exist in the nation and don't really acknowledge their presence. Even when you think about the data that we report, we don't even report data on American Indians and Alaska Natives because oftentimes we say the numbers are too small. There's a book called Beyond the Asterisk by Heather Schotten that talks about being tired of hearing, well, the numbers are too small, we put a little asterisk, we didn't include American Indians and Alaska Natives because the numbers were too small. And so when we talk about engaging our minority serving institutions, we have to really support them. We have to build them up. We know that some of them are struggling, but some of them are really the bastions of excellence where many of our students are. And we need to go to them. We need to develop more partnerships with the minority serving institutions, and including the community colleges. We did a lot of work over the past few years with the Robert Johnson Foundation with the pre-med program. Now it's called the Summer Health Professions Education Program. We attract over 1,000 young people each year to pursue, initially started with medicine in 1989, and Alden is a product of that program. All the way through now, we represent health professions, and we realized that if we really wanted to make a change, we needed to think differently about where we find our talents. And community colleges are really the place to go when you think about especially students who are economically disadvantaged, but also those who are historically underrepresented, African American, American Indian, Alaska Native, and Latino. And if we don't go to these places to encourage them to come to us, they're not going to come to us. And so we find that that's where we have a lot of richness in terms of talent that often is neglected because, unfortunately, many of our institutions think that they have to go to a certain place or they go to the same place every time and we get the same results. And so we really have to go beyond what we think are whatever the most highly qualified or how we define that, right? I hate when I see qualified applicants in any article or anything. It's like, what does that mean? Unpack that. How are we defining that? And so really that's what it's about, going to where students are.
Yeah. And I think the theme that I'm hearing from many of the comments that are being expressed is about distance traveled and making sure we're identifying students who've had to overcome a number of circumstances, not just educational disadvantage, but economic disadvantage and whatnot. So, so this is really a two-part question, and I really want to tease out how do we make sure that when we talk about diversity and inclusion, we're not eliminating people who are on the fringes, whether it's our rural populations or other individuals who are coming from other disadvantaged populations, especially our Asian American colleagues. We often think about them being overrepresented in medicine, but when you really parse out the numbers, there are certain communities that are underrepresented in the healthcare fields. So maybe we'll start with that. So Norma, I know you've had a couple thoughts about that, and Donney, I want to hear your comments about making sure we're addressing the intersectionality that may come along with diversity and inclusion, but also other groups that are often overlooked.
You know, at the AMC, we always struggle with this because, you know, for us, when we started talking about inclusion, many of our community members felt that we were kind of diluting our focus and losing the focus on our historically underrepresented groups. But we find, to your point, the intersectionality is so critical in terms of the experience of individuals and creating environments that really, if it's not, it's almost like universal design when we think about individuals with disabilities and designing things so that it makes it accessible for everyone. That's really where we're focused on, because if we help one group, really we end up helping all. And so but we also know that there are key challenges. Our Chief Diversity Officer, David Acosta, is very clear to say when people are like, well, what happened? Why are you so focused on black men in medicine? And he's very clear to say, because there's a crisis. Look at the data. When we think about American Indians and Alaska Natives, there's a crisis. So the data tells us where we need to really hyper-focus, but that does not mean that we're losing other communities. It just means that we are saying, if we help this community and we solve this problem, we're gonna be much better off for everyone else. And so for us, you know, our inclusion is a very important issue for us because it incorporates thinking about how our environments can help everyone thrive. So it's not leaving one group out or the other, but it's acknowledging that, again, in reality, in the society we live, we do have some groups that are suffering, and we need to focus on that. But we're not losing any energy, or focus on other communities as well. When we expanded our work around LGBT issues, and again, I mentioned our data on economic status. We have a lot of our members who work on rural issues, so it's not that we don't care about those, but we recognize where we need to make an emphasis and where there's a real crisis.
Donney, and then I want to come to you, Fatima.
So Dr. Joy Perry had mentioned on Saturday that there is this legacy effect, where if you grow up in a family where you have medical professionals within your family, you get to see and have that conversation. So you learn from that. So within the Asian community, you have a choice growing up. You either go into medicine or you go into technology. You know, you don't really go into law because that's not what Indian people do. You don't go into business. You go into these safe, environments. But the problem is that you don't see people that are in medicine or within technology or certain industries elevate themselves. They get comfortable. So the problem is that we don't have a lot of exposure of people kind of stepping out of their comfort zone and kind of challenging the norm, being different in what they do. So I remember that when I was at St. John's, I was the first and only pharmacy student that actually was part of the summer orientation program. So we had about 400 kids in our program, and I was the only one to be the orientation leader for 400 kids for this big pharmacy program, because at that time, the tuition dollars came from pharmacy and allied health. So I had pharmacy, nursing, pharmacy and PAs and other allied health professionals underneath my purview to be the orientation leader for. And everyone's like, and I'm always asking, well, why is there not other people? And after I started to get engaged and kind of pseudo-mentor people as I went along, that's how they all came in to follow my lead afterwards. But it was just me getting out of my comfort zone. We don't have enough people that will go out of their comfort zone and take leadership, because we want to get to a certain level, we make a certain income, and then we don't rock the boat. But you do have to rock the boat. In order to make things happen, you do have to challenge norms, you do have to build consensus. And that's one thing that, we have to get comfortable in our own skin, in being able to be vocal and not be marginalized, regardless of not just advocating for one point of view, but advocating for all points of view, to be really heard and be thoughtful in the way about doing it. And when you talk about medicine, medicines don't work the same for everybody. Precision medicine, the whole concept is customize and tailor the regimen towards the individual. But when we don't have enough research studies that show within the Asian group, within the African American group, and the Hispanic group, how drugs work, and then when you talk about coverage, who's going to pay for it, that becomes another conversation. And we do need to do more in those arenas.
Fatima?
So when I think about what we're doing, I think that we can leverage groups in organized medicine to really get across our message. So I'm at the Minority Affairs Section at-large delegate for the American Medical Association. And one of the programs that we do is called Doctors Back to School. And I encourage each of you on Wednesday morning, bright and early, is it like 7 o'clock for you guys, to come with us as we venture to one of the schools here in DC, as we do every year at the NMQF. And when we go out, we go and speak to students, and they get to see our faces. They get to be involved and engage with us and ask us really any questions that they ask. I think the number one question they usually like to ask is how much money we make, and they are often very disappointed when they find out what I make. But that's very important. And when we're thinking about working with different groups, our vice chair currently of our Minority Affairs section is a woman who is an Alaskan Native. She is one of 3 physicians in her tribal history to become a physician here in the United States. She went to medical school at Harvard Medical School at the age of 37 after kind of being told she could not do this, and obviously has been successful with achieving that. So I think that when we leverage groups like the AMA, large groups that are able to go out and make impacts in all pockets of this United States, I think that we're able to reach those marginalized populations and really get across our message that we are here and we are ready to serve.
I want to jump in here and build on what Fatima said in terms of leveraging agencies of different organizations, and also talk about, we talked a lot about sort of the K through 12 and into medical school, but on the backside of that pipeline into residency and to becoming a faculty member, we've got some major challenges from a diversity perspective. We had a chance to work with Dr. Bill McDade, and newly in his role at the ACGME as a Chief Diversity and Inclusion Officer, to ask the question, well, what's going on in terms of diversity in our residency training programs? And he startled us with some data looking at the state of Illinois, where I reside. There are approximately, for example, 157 orthopedic surgery residents in training across the entire state right now. Now I'm going to pause and say that when I finished residency at the University of Chicago, one of my peers, Greg Primus, finished his orthopedic residency at the time, and I didn't realize at that point he was the first African American in the history of that orthopedic surgery program as an African American to complete it. Now Greg also was an NFL player, former Bears player, former Broncos player, took that to break that color barrier at that institution. So today, 157 residents trained across the state. I think there are like 2 or 3 African Americans, 2 or 3 Hispanics, no Native Americans. Ophthalmology, no African Americans, no Hispanics, no Native Americans. Urology, 1 African American. Otolaryngology, radiation oncology, you see a similar pattern there, right? So we've got a lot of medical students in the pipeline that are applying for residency programs, all right? But there's something happening on the back end in terms of identifying who are the ideal candidates to come and serve in these areas. And again, the reason why it's important, not only primary care is very important, but specialty care is important as well. And providers have implicit biases, patients have implicit biases as well, right? So we want patients to also come to the table, you know, and be able to trust their providers, follow some of their guidance, and actively engage. When we're not addressing some of the different facets of this pipeline, it causes problems. And so I will say that as a health insurance company, we're in this unusual role of asking a question of our academic medical centers, our hospitals that are training residents, how are you doing in the area of diversity and inclusion? Because usually that's not the conversation. Usually the conversation is around payment and rates. But now let's look at what's happening in terms of the output of the training programs that you have. How can we ensure that those are more diverse to meet the needs of a diverse population that disproportionately bears a high burden of health disparities, which we know represent excess direct medical costs in the healthcare system? And more importantly, shorter lives, less time that individuals are able to spend with their family members, and that's something that's very important to address.
And you could just carry that on up the chain, continuing down the pipeline, whether it's who becomes assistant, associate, and full professor, who becomes a department chair, who becomes a dean of a medical school. The further up you go, the less and less diversity that you're going to see.
And I think to your point of disaggregating the data, and especially for Asian Americans in the United States, we find that although there's a high representation of Asians in medicine, and then even the second largest group within academia, when you look at basically going along faculty ranks, they pretty much have the same experience as African Americans, Latinos, and American Indians in terms of moving from assistant to associate and being represented in leadership roles. And so that's critical for us as well, to think about what are the interventions that we consider early on when we talk about early exposure for young people to pursue medicine. Dr. J.P. Sanchez at Rutgers University is a founding member of the Building the Next Generation of Academic Physicians, really working with institutions across the United States to expose medical students and residents early on to careers in academic medicine, to let them know, to bust the myths, because many of them also feel like, well, I have to be a bench-side scientist in order to be able to be successful in academia, really understanding what the roles are and really clarifying what that process is, because many individuals don't know. If you've never been mentored, if you've never been taken under someone's wing to really understand what a faculty career is like, you don't think it's possible, especially if you don't see individuals maybe who look like you. And so that's critical as well, to start very early on exposing medical students and residents to careers in academic medicine. I mean, research shows that individuals who start research exposure as early as you mentioned, right? College, your exposure early on, those individuals are more likely to pursue careers either as PhDs or as MD PhDs. And so we want early exposure is critical.
So I just want to move along because I know we're getting late in the evening. So Vernell, what's working in nursing when it comes to workforce diversity? What successes have you seen that are out there, and maybe our audience may not know of these experiences, these opportunities that are successful?
Well, we engaged in a number of pilot programs. For example, for 8 years, I directed the Robert Wood Johnson New Careers in Nursing, which really did increase the diversity in nursing. We had some 3,000 students go through the program and become licensed nurses. What happens too often is that we have pilot programs with good outcomes, and then they're not sustained. Mm-hmm. And I think one of the greater issues, I don't know about the other disciplines, is the sustainability. You create something, it works, and then it's gone. Mm-hmm. Right now, we're engaged with looking at holistic admissions review. HRSA has funded a number of schools, 34 of them across the United States, and we're working with those schools to implement holistic admissions, and now that's getting to be a little bit of a buzz in nursing. Medicine and dentistry were well ahead of the curve when it came to that. So we have models that work, but without funding to sustain those models, they lose their momentum.
Great. Donney, did you have some thoughts on what's working in pharmacy?
Pharmacy, one of the things is that there's a lot of postgraduate training. So now it's not only going for 6 years or 8 years to get your doctoral degree, but you have to go for an extra year of clinical training in different disciplines. So one of those things is that a lot more universities are starting to offer clinical residencies, but it's also getting the word out to students that there is opportunity, and it is very competitive, where you have an overabundance of students but not enough residency positions. And when employers are asking that you need to have this as a minimum, it becomes very challenging when you're living in an environment where you don't have the luxury to go out of your state or your region for that training and to get a job. But pharmacy, there is a lot more in terms of opportunity with fellowships, where pharmaceutical companies are spending a lot more effort to recruit and engage and do STEM-based activities. So it's really helpful for that perspective. But also pharmacy schools, especially student organizations, are getting more involved, trying to be more visible within the community of just being actively engaged, because that's extremely important, is to be seen. And that's one thing that they are doing a much better job now.
So I want to get ready to open up the microphones to the audience. So if you have questions, I think there's a microphone on either side. But Fatima, before we open it up to the audience, can you talk about how we can get more diversity in the physician-scientist realm?
So I really think early exposure to clinical research, starting really at the elementary school level, it sounds like absurd, but I think getting that exposure very early is when we start to really attract persons to research careers. Doing that program with the NIH very early and actually competing in the International Science and Engineering Fair representing the United States made me feel like I can do this. And even though as I made my way up and have gotten 16, 17 grants rejected over time, you know that, hey, but I'm capable of doing this and I'm capable of contributing to the intellectual knowledge in my field. So I think early exposure through large government agencies such as the NIH, RWJF, these types of programs are crucial, and having our children realize that, hey, when I compete, this can go on and to be publishable data. So I think that's early exposure, and filling those outcomes, seeing that you actually can do it and you've actually contributed to the literature is important. One of the things that I told one of my former mentors at a conference I was just at a day or so ago was that, you know what, the one thing I think you didn't do well was allow me to publish with you. And I think I could have been on these publications because I was doing the research. He says, I think you're okay, I think you caught up. But I still think it would have been nice to have been published. And what I'm doing with my medical students is I'm making sure that if they're contributing to that body of knowledge, they're on the paper. I will make sure that they're included on the paper. So, it's not something, and they're willing to work. They're willing to do the work, and they know how to do it if you direct them accordingly. And so my medical students, I think, publish more than a lot of the students because I want to make sure that they have what I didn't have.
So I'm going to turn the microphone over to you for questions. Please. Short questions without monologues. We'll go here first and we'll just alternate. Yes, ma'am.
Good evening. I'm Dr. Joya Creer-Perry, the president and founder of the National Birth Equity Collaborative. I would love to ask Fatima about obesity stigma, but I'm not, because that's what this panel is about. So I would appreciate, Derek, your conversation around the physicians in Chicago and how when you took out where the black physicians were, there was no access. Because there's a lot of language around black serving hospitals, black doctors, and around how the people are more likely to have poor care in those situations, right? So we heard that even earlier on the panel that I was on. And there's a lot of data and research around that. But we don't talk about the resiliency that happens in those places, despite the fact that black doctors and black hospitals are treated like black people, which is poorly, right? Underfunded, they don't have the resource. So how do we find a way to reframe how we talk about institutions that have been historically underfunded, who have historically been taking care of people who have come with, who are overburdened, and not problematize the institutions and the individuals, but actually think about them as resilient and strong?
Sure, great question. So brief answer I would say is that I think we have to look at what are many of the factors that contribute to the challenges that those patient populations and the institutions that serve them are dealing with. And a lot of those are not healthcare related issues, right? And so we have to ensure that we don't retreat to our respective corners and say, well, hey, this is a public health issue, this belongs to the city, this belongs to this organization. We have to figure out how can we leverage our political capital, how can we leverage our investments as corporate citizens or various organizations in a city to address those challenges and help lift those communities up so that we remove some of those systemic barriers that lead to some of the adverse health status that we see in those communities. And so I think understanding how we got there and then beginning to address some of the challenges is extremely important.
All right, thank you.
Thank you. Yes, ma'am.
Yeah. Hi, I'm C. Freeman. I'm the first African American president of the Los Angeles County Medical Association. I was very interested in the conversation around making the calculated choices in terms of challenging the status quo and diversity. And my father is one of the first African Americans to receive his PhD in philosophy from the University of Chicago. So here we are 80 years later, and I want to know, how do you make those calculated decisions in the positions that you hold to address the issues that we have now without losing your job?
So
Quickly.
So there's always a question of, people will complain about the situation. And I know when I was early in my career, people would say you can't do certain things, or that this profession stinks and this is really wrong path to go. And I would ask one question: what are you doing to make it better? Because we can complain a lot, but if we don't have a solution or a way to kind of improve our environment, it becomes a drain. So one thing I've always done is try to really help people identify what can they do within their own situation to improve. What are things that they can think outside the box to apply different mindset and have more of a diplomatic approach to having conversations. And kind of, it comes with experience of just knowing what you can say in one setting versus another setting and what's the business interest for both parties involved. So that way you can be as politically correct as possible to move the needle forward. But it's always thinking about, don't complain, come up with a solution, and let's see how we can work to implement it.
And just to piggyback on that, I think there's some things that are out that are going to make our jobs a little bit easier. You mentioned about the diversity in residency education. Well, the ACGME has these new guidelines that are coming out that really aren't fleshed out. LCME has expectations for what medical schools should do. I'm sure there's requirements for other schools in the health professions, but we can use those as ways to push our institutions of higher learning to be more inclusive, to be more diverse. And we can do that by being either the thorn in the side of the people who are the ones making those decisions about the admissions process, or we can be their allies and help them, saying, hey, look, I understand you have this problem. Here are a couple solutions that I've seen that are impactful that you may want to try and incorporate. And sometimes you have to be a little bit of both. You have to be, the carrot, and you have to be the stick. So we'll go here.
I was just going to say, Alden, I would just add to that. I think coalition building is critical because maybe you as one organization can't say something, but you partner with another who has the freedom to say certain things. So for example, when we wrote the report Reshaping the Journey, our colleagues at AAIP, Association of American Indian Physicians, would say, yeah, medicine is racist. There's certain things that are happening that maybe we couldn't say, but there are realities that exist for different communities, and using their voice and I think giving different communities an opportunity, a platform to raise their voice in different ways can help when you may be limited in how you could communicate something.
Quickly.
Sam RCM from New York, St. John's.
Yep.
I am a dinosaur. I don't believe I said that. I went to school when the big deal was to discourage you from going to school, to med school. And so I had more people telling me that I had to choose other professions than what I wanted to do, even though I wanted to be a physician from when I was a kid. And I probably am the first college graduate in my family. But about a year and a half ago, I was invited to go speak I will leave the school nameless, so that just in case it's in Ohio. They invited me to go speak on diversity and inclusion. And I went and spoke, and it was interesting because by the time I finished, they had asked me for my slides and my presentation to give it to the entire faculty. But the point was that I thought that they needed to be intentional about going out into the communities and getting the students. Now, I am the first to believe that we are as smart as every other group, maybe with my exception. So we don't have to ask for any favors. We are just as smart as everybody else. But for some reason or other, we may not have the chances or the luck that other groups may have. So I'd like to know what you think about, one thing is quotas, the other thing is to be intentional about going into the communities and pulling out these kids and encouraging these kids. So I'm wondering, by the way, when I was going on my way, it's interesting because when I was on my way to the airport to come back home, I stopped at a street type of vendor, flea market, don't judge me, at a flea market, and as I'm going around, one of the vendors looks at me and says, "Boy." Now, I think the only time I was ever called boy was on my birth. Maybe my mother hadn't named me yet. But I wasn't used to being called boy.
Sure.
And so, to tell me,
so maybe
boy,
what I'll do is I'll stop you there because I have a great way to introduce, sort of reframe that question that you were posing. So Norma, you talked about what the Summer Health Professions Education Program and how you started as part of our charge from Robert Wood Johnson Foundation on how to make sure that we are recruiting locally and asking the summer programs to actually look at the students coming from their own backgrounds, their own backyards. So can you talk about how impactful that was and what you had to do to get the schools to buy in to make sure they were recruiting locally?
Yeah, I think it goes back to your point of the levers of change, because we work with the Robert Wood Johnson Foundation to ensure that as part of the grant application, it was required for the program sites to recruit within their state, within their region, and it was very startling. What we found was some of our program sites that were funded for several years weren't recruiting students from within their state. And once we had that mandate, it changed dramatically, that even the dean of a said medical school approached our PI and said, "Wow, I didn't believe there were Puerto Ricans and black people behind, my backyard, that I didn't have to go very far to find them." And so it's really incredible how many of our institutions, think about, back to Vernell's point, there's so many applications that sometimes they could be passive recipients, right, of their applicant pool and not reach deep into their community. So I think the levers, and back to what Derek is trying to do also in Illinois, is really to look at what are the levers that insurers have to help motivate individuals to act differently. Perfect.
So we'll go here. Hopefully it's brief.
It'll be briefer. I won't even say my name, but what I will say is that when we're talking about pipelines, there are people like Bill McDade who interviewed me 19 years ago for medical school, and I was accepted to the University of Chicago, that now I can call Bill instead of Dr. McDade. 16 years ago, it was people like Dr. Joan Reed when I was an MPH student at Harvard that brought me into that pipeline. Years later, it would be Dr. Edwards who would recommend me to be one of the 40 under 40. And coming here is like home because we can talk about these issues. We can talk about the aptitude, which is what the pipeline is. You have to have the aptitude to get into the pipeline. But there are so many other things you have to learn that are beyond the aptitude, but really about the culture. And so for all of you sitting on this stage, there are things you've had to learn. I think it was the AAMC. They do something for women in medicine. And I felt like they talked about imposter syndrome. What is that? And I've been feeling this all along. There are these other things that have nothing to do with the aptitude, but a lot to do with how you're going to survive at a Harvard, how you're going to sit at the table with predominantly white men at the Blue Cross Blue Shield, how you're going to be at the AMC, those other things where if you were on that panel now, you would be speaking a little bit differently. Where did you learn it? How did you learn it? And how do we make sure that our students that are coming through the pipeline get that learning learning as well, so they can be leaders and successful at the highest of levels.
Fatima?
So, Renesia, I think that's a challenging question. I don't think there's an easy answer to that question, because I do think that one of the things that we haven't talked about is how it is to actually be in these settings, so you can get there, but are we often welcome in those settings, and how do we navigate it when we're maybe not welcome in those settings? And I think that it's, I don't think I have the answer, which is not a thing that's normal for me. But I think that I usually have an answer for something. I come up with something. But I think that what we have to do is recognize that there's a certain level of decorum that you have to have in settings that are more majority. A lot of that comes from, I just say life experience and being in those settings. But I think what this brings up is that, unfortunately, and I know about your background and how you were raised, that you don't have exposure to those settings early on. And so you really have to learn cues within your environment to shape how you would think and interact within that setting. And it takes time. And I think that a lot of us probably are still learning of how to navigate that on a daily basis. So that's a not answer to your answer, but a very politician answer. So
I'll offer a couple of thoughts. Prayer, grace.
That's good.
Amen.
And I would also say, I think our experiences are graduated, right? And so at different levels in that experience, I think your risk tolerance changes. And that's a part of this as well. I mean, you have to be willing to take some risk in order to make change. And sometimes that risk could not go in your favor. And that was part of the question someone asked earlier. But I think also if we made all of our decisions based upon our fears, we wouldn't have made a lot of decisions that we made to move forward, and a lot of folks wouldn't benefit from it.
And I think you were fortunate because you mentioned all those wonderful people who've played a role in your life. But the role of mentorship cannot be undervalued in these types of situations.
Agreed. Being a mentor is important, but what we're learning is that having a good coach is even more important. Because a coach is going to open doors to opportunities for you. And I think the coach piece is probably more critical than the mentoring piece. Growing up during the civil rights age, you learned a lot. You learned to read body language. You learned to hear the unspoken word. And I think in times you learn that along the way. And you learn how to respond to some things, and you make an informed decision not to respond to some things.
Thank you. Go here.
So pipeline programs, right? Programs to allow people to clear the bars that exist to make it at each level, get into college, medical school, et cetera. Getting into college, racist. Getting into medical school, more racist. Getting into residency, that's very competitive, extremely racist, right? They talk about fit. I'm a neurosurgeon. In neurosurgery admissions process, it's all about fit. Oh, we like this guy. This guy fits in with us. We like to hang out with this guy. He's the guy we like to have a beer with, right? So pipeline programs are fantastic. They're going to help people fit the existing racist bars that we have right now. But what about changing the bar? Right? What about changing the processes so that the people that we have make it? How many of us know brilliant people from undergrad who wanted to be physicians, that were in biology class with us or organic chemistry class with us, and never became physicians and are brilliant other things because the bars at our institutions were racist and they didn't make it? So what can we do to change the bars, including the pipeline programs are phenomenally important, Tour for Diversity, things SNMA, et cetera, are doing. But how do we change the bars and the places that we are so that those individuals that are already interested get into the programs that we're at?
I think it's what Derek is doing, where employers have to be the voice, because you can't, one of the things is in academia, you can graduate a bunch of different students in all these professions, but if employers don't value the value in diversity, then there's no real point, because you have a well-educated individual, but they're unemployed. They have a lot of debt. That's about the only thing they get besides education and debt, but they have no opportunity. So it's really the employers that we have to work on, where employers have to see the value of recruiting and putting people in the place. So it's kind of like getting called up for the minor leagues. You train, you get there, but then get called up to the big leagues, so you're giving an opportunity to succeed. But it's really the employers that have to value the diversity to hire and recruit. And so that way, you have more of the bar being elevated because it's employer directed. Because everyone says it's a free market economy, let the economy decide. employers have the tools to kind of make the decisions. So what Derek's group is doing of asking those questions is extremely important, and I would commend him for his organization of actually taking the lead to ask those questions.
Did you want to jump in, Derek?
Well stated.
Perfect.
I was just going to add, part of it is, you know, for us is looking at the culture of medicine more closely, which is the point that you're making, really understanding. I think now when there's a greater focus on physician burnout, for example, and that's across all the health professions, and really looking at wellness, it really gives us an opportunity to really expand that conversation to say, well, how does that look for different people and from different backgrounds? And what does that mean? What does burnout mean for a physician of color or for faculty of color? What is it within the climate that's contributing to these environments where not everyone is thriving? And really, again, going back to the data, and we're focusing a lot at the association on various assessments of the culture and the climate at institutions, giving that data back to say, what is it that we need to do differently? So I think really being able to assess those cultures, and you're right, we have to change the culture because we're all not gonna fit in, right? But really looking at what is it that exists right now, and how do we measure it so we show people that it's really happening, that it's not just the subjective experience of only a few, but it's a reality that needs to change.
And I would also just add that we need to use the policies that are in place that we know and use those as to our advantage to increase diversity. But then I also think that we need to be in positions to make those decisions about who gets in. So we need more program directors of color. We need more deans of admissions of color. So we need to be fighting to get those roles as well, and not just going for the chief diversity officer positions at institutions. Yeah.
Good evening, everyone. My name is Dwayne Taylor, and I'm an otolaryngologist, head and neck surgeon, and I will be the next president of the American Academy of Otolaryngology, head and neck surgery in October, and the first person, African American, in that position. My question is, I'm in private practice, and we talk about mentors, we talk about people who can make a difference. And we have to be able to come up with solutions, as you mentioned, about wellness, of how we can help these mentors who are also struggling. I was the only African American in a BSMD program in my class, and I can't even begin to tell you the experience I had with that. However, you know, when you have a group of people that you want to be mentors and you want to help pull individuals into a pipeline, and they don't have the support. They're still fighting battles, especially community physicians. We've spent a lot of time talking about academics, sure. But community physicians who are also struggling in many ways, and you wouldn't believe over the years, you think things have changed, but many things have stayed the same. So could you comment on that? Anyone?
Any thoughts?
You know, I'll just jump in and state that you identify a significant problem, and I don't know that I have a solution to how do we support the needs of the mentoring physicians that have been in a struggle for a long time. I will say that Dr. Bonnie Mason has a nice program called Nth Dimensions, where she's doing a lot of work to help strengthen diversity in specialties like orthopedic surgery. ENT may be ripe for something like that, and I think what she does with that is connects individuals like you who are in these specialties that are not very diverse, and helps really wrap the medical students around individuals like that, so that the reality that they see is different than what you'll see just out in society in general, and really build them up over that M1, M2, M3 years, so that when it's time to apply for residency programs, you know, they are best prepared to be that competitive applicant. And then also working with the training programs to help them redefine how they see a competitive applicant for those programs as well. And that in itself could be a mechanism for soothing some of the pain and the challenges that the community specialists face as they're kind of fighting the battles as the only one in their community, trying to serve their patients, and then also trying to mentor people that are coming behind them, and not paint a bleak sort of hopeless picture for them, you know, clouded by the experience that they're having as they're dealing with their own struggles.
I just want to add, part Part of it is also leveraging technology. There's so many resources out there. I know AMC started early on with aspiring docs, really featuring different role models, having information, because a lot of it is access to information, right? As you mentor students, is letting them know what that pathway is. There are a lot of resources that exist online. You know, students follow like Twitter hashtag Black Men in Medicine. You know, there's so much out there in terms of Mi Mentor, other resources that, you know, community physicians can lean on to connect students with. Recently at the association, we started a virtual career fair because we know that some students cannot get to certain places. So I think accessing, looking for those connections, those organizations that are already doing similar work and connecting students, because there are opportunities to connect to other resources. Someone mentioned the Student National Medical Association is another great resource. And so I think that's an opportunity there to think about what are some partners that you could have to join you to kind of basically minimize unfortunately, sometimes it's a burden, right? And we call it kind of the brown tax, but it's also part of what we feel drawn to do, and we feel is part of our own personal mission. So thank you for the work that you're doing.
Thank you very much, and thanks for everyone being here tonight. Thanks to such a great panel. I'm Edith Mitchell, and I am a clinical professor of medicine and medical oncology, Thomas Jefferson University in Philadelphia, where I head the Center to Eliminate Cancer Disparities, and I am Associate Director of the Cancer Center there. I am also retired from the Air Force, where I was the first woman physician to be promoted to the rank of Brigadier General in the history of the Air Force. And I have seen diversity, disparities, lack of mentors, you name it, in many areas of my career, both in academic medicine and in the Air Force. And my question to the panel tonight is related to our vernacular. When I was in medical school, we were referred to as African American or underrepresented minorities. I noticed from the moderator tonight, his challenge to the team was, and to the panel, was people of color. And of course, people of color, in my opinion, is just a dumping bag. Because for many individuals who are people of color, maybe darker complexion, apply to many of the pipeline programs that I've seen. In academic institutions where I've had the opportunity to review many, they are referred to as people of color. And there are many individuals who have color in their complexion, but they're not underrepresented minorities. There are underrepresented minorities, and particularly the Alaskan and Native Americans, and yes, I had an assignment in the military in Alaska, where there is a tremendous disparity in individuals entering medical school and other healthcare professions. So my question to the group is, have we diluted our ability to help underrepresented minorities by using this hodgepodge of people of color? Why don't we refer to, as every panelist here did tonight, underrepresented minorities in your comments and your discussions, but yet we got this hodgepodge of people of color that in many cases has nothing to do with underrepresented minorities, or it has underrepresented minorities dumped in with others that may not be underrepresented in the medical professions, yet they may have some color in their complexion. So my question is, do you think this has diluted our efforts in getting more people into pipeline programs, into residency and fellowship programs? Can
so Norma,
any of you reply to that?
Norma, do you mind just sharing the definition for underrepresented in medicine as best you can?
Yes, so URM was underrepresented minority, and then in the mid-90s, in response to the changing socio-political environment, part of it was a discussion at the association of how do we define URM, and based on feedback from the community, it then became underrepresented in medicine so that every institution can define it locally. But we know that based on going back, like I said, going back to the data, we know that there's significant underrepresentation based on each racial ethnic groups, particularly African American, Latino American, Indian, Alaska Natives. And so in terms of people of color, I think sometimes it's used interchangeably. I understand your perspective of how some may view it as diluted when you're not specific, but we do try to be very, at least from our perspective, be very specific about the type of group and how we disaggregate the data, because it is very important in terms of talking about underrepresentation. But it is used, even URM is used as a blanket term. Alden mentioned earlier where some Asian American ethnic groups, like Hmong, for example, in California are significantly underrepresented, where that might not be the case, let's say in New York, for example. So part of it, the most recent iteration of the definition is more flexible, where it could be defined more locally.
No, I totally understand that. However, I think it has contributed to effectiveness of our programs. For example, for many American Indians, Native Americans, Native Alaskans, they don't have excess color in their complexion, and yet there are others with excess color in the complexion who get into these programs as minorities, and they're not. So, in my opinion, I think we have to say what we mean and mean what we say. And when we say people of color, it's a hodgepodge. When we say underrepresented minorities, we're really reflecting those individuals who are underrepresented in medicine, and consequently, those are the ones that we have to offer the assistance through mentoring that will allow them to get into our medical schools and other professional schools.
So, I think we have to do that and a little bit more, because the issue that I think you're driving home is that we have populations that, because of the history of our country, have experienced historic oppression. And so if you don't zero in on specifically the challenges of those communities while also being inclusive of others, then you don't begin to change the numbers. You don't begin to change the impact. And when we look at those same communities, they have tons of disparities and a variety of different social determinants that impact those communities. So I think we have to talk about, the Latino experience, the Native American experience, and the African American experience. And then we also have to look at what are some of the challenges that are faced by other diverse populations. But I think we have to do both, because if we don't do both, then we're not going to move the needle.
And I agree with you, but not all people of color are underrepresented minorities, and I think we really need to focus on those individuals who need our help.
So I think that's a nuanced question that we can answer at a different point. I just want to get to our last comment, our question. Please make it quick so we can wrap up for the evening.
I like how you went straight to comment. First of all, thank you all very much for your incredibly wise words on this subject. I'm Taman Osborne Roberts. I'm a family physician. I'm Chief Medical Officer for Colorado Medicaid, as well as the Colorado All-Payer Claims Database. And I wasn't going to mention this, but since everybody else did, I'm the first person of color to serve as president of the Colorado Medical Society and the youngest person to serve as its president in the 143-year history of the organization. My question actually has to do with culture, but not so much a culture of racism, but the fact that we are a range of people who are living in a Western culture who are partially from outside of it. One of the things I've seen in regards to recruitment and retention is the fact that in most of our cultures outside of this Western frame, the infrastructure of joy is a big thing. Happiness, family, fulfillment. I don't care if it's the barbecue. I don't care if it's carnival. I don't care if it's the family dinner. I don't care if it's the quinceañera. I don't care if it's the powwow. Whatever it is, we get together, we connect, we're human, we have fun, and that is not something celebrated in the Western frame of medical education the way it's set up now. So how do we address that in a way to make what we do and the many years of training we have to put in more attractive to the people who might be thinking about this, looking at it and going, I don't need that pain?
Anyway.
Man, I want you to come back to the mic.
Yeah.
Throw it back at you a little bit. So Taman is on the American Medical Association Foundation Board. So I would ask you, Taman, as looking at the use of organized medicine to maybe uplift some of these ideas of family and fellowship, how do you think that we can do that in our bigger groups, not just amongst the people that are left in this room tonight?
Because I know where this is going, and 30 seconds, because we have a wonderful group of people who want to go watch a basketball game or do some other experiences, so please,
Kevin told me
30 seconds.
He left.
I was seriously asking that to y'all. But realistically, honestly, I think a lot of it comes down to bringing it up. I mean, we don't talk about that in medicine. We don't talk about the pain and the sacrifice. It's like becoming a parent. Everybody's like, have a kid, and then they don't tell you about all the difficult parts. Really, we don't address it. I would say from a personal level, a lot of it's just addressing it if you're in a position of power to do so, but, I'm not faculty. I'm not in a lot of places who you are. I want to hear your answers.
Yeah. So I think mentorship is important in making sure we share information about both the good and the bad. Oftentimes we try and paint a picture for individuals about a career, what it may look like, but we also don't necessarily share the negative. And I think that's something when we're having honest conversations with our mentees, many of which have only one view of profession, if we need to give them the other side. Not necessarily paint it all in a negative light, but make sure they have a full understanding of what they could be getting into and how it may impact every other decision when it comes to family, going to those barbecues, those family events, how you may have to sacrifice, how you may have to experience delayed gratification, whatever it may be in order to get through this process. But then also understanding that it can take away from you and lead to burnout and stress and all those other things that we talked about, the opposite side of wellness. So I want to say thank you to our panelists. And I want to say thank you all to sticking with us so late in the night, and we'll see you bright and early tomorrow morning. Thank you.